Alright, hey guys, we're going to be covering week 3 radiology today. And what we covered in lab was the Reiser-Ferguson, Cobb-Littman, and then how to measure kyphosis, lordosis. So what we're going to do right here, the Reiser-Ferguson and Cobb-Littman is all about measuring for scoliosis and finding out what the degree of scoliosis is. So in order to do that, we'll go ahead and we'll start with the Reiser-Ferguson model. And what you want to do is you want to find out where the scoliosis has protruded the most, where it's sticking out the most, and that's going to be considered your apex. So what you do is you just take your rolling ruler and you move in until the first vertebrae hits. And so right here that's going to be T7, so we'll just mark T7 here. Alright, and from here you can move up. And as you kind of just move along, so you can see how the rolling ruler starts to scroll, and as it starts moving in this direction, it's a left-hand turn. And once it stops turning left, which would be right here, see it's no longer turning left, it's starting to turn back to the right, making like an S bend. This is going to be your superiormost vertebra. So it's going to be T4, so kind of where the scoliosis ends. And then you do the same thing moving down. So I'll just move down, and so I'm moving out here, and all of a sudden it starts to come down, moves it back around. So this is where we're going to end this one. So that'd be T9. Alright. And from here, what we're going to do, we're going to go the inferiormost aspect of T9, and we're going to draw out a line. Make sure this is the right one. Good thing I double checked. Alright, so that's, I was starting to do the Cobb-Littman. We want to do the Reiser-Ferguson. So here what we're going to do, actually, we'll measure it out here at the end. We're going to make it cross-check across the vertebra. Alright, do the same thing at T7. What we're trying to do is we're trying to find a center point for each vertebra. And we'll do it at T9. Alright, and then we will make this is a very big ruler here, but we want to draw through the two bottom center points. So on T9 and T7, draw a straight line going all the way through. So I'll just do it like so. Alright, and then through T4 and T7 do the same thing. Alright, and this right here is the angle that you would want to measure, or this angle. And this is a good one for the patients because you can actually see whether or not your scoliosis is getting better or worse. This has kind of become a mess up here, but it's between these two angles. So you can tell, like it's obvious for a patient, if this starts to get better and it's more in line with a straight line, then their scoliosis has decreased. Or you can tell if it's gotten worse, is if that angle is starting to get better, or it's getting bigger. So the Cobb-Littman is a similar principle. We're taking the ruler, finding the most, finding the apex here. So it's between 6 and 7. It really doesn't matter which one you pick because they both, the ruler strikes these two first. So you just pick one, but you just gotta stay consistent with the one that you pick. So we'll just pick 7 again. We'll move up, and these are identical, so to save time, it starts to move, make an S-bend, and then it comes back. And so we know 4 is the superiormost, and then going down makes an S-bend again, and 9 is the most inferior. So from here, we're going to draw a line on the concave side, on the inferiormost aspect of the inferior vertebra. And on the superior vertebra, you draw a line on the superior aspect of the vertebral body here, going in towards the concavity. And then we're going to measure these lines by drawing a perpendicular line out. Just with the rolling ruler, take it from the body and draw a line out. I'm going to have to do a little bit different because this is a lot bigger than a normal spine. So draw that line, perpendicular line out, do the same thing here. Alright. Kind of mix it up a little. But this right here is the angle that you're going to measure. So you take your protractor and you'll measure this angle or this angle, either one. And if it's between 0 and 20, you want to observe it for progression. And progression is a 5-degree change within 3 months. If it's between 20 to 40 degrees, then they recommend that you have some sort of bracing. And if it's greater than 40, they typically recommend surgery. So we don't necessarily have to go by these, but we need to know them for the test and for boards. Now what we're talking about here is for kyphosis and lordosis. What we're going to do is, it's going to be similar to the Cobb-Littman. We're just going to be measuring here. The one thing that's different is C1. C1, you're going to put a dot in the center of the anterior tubercle and on the posterior tubercle. And you're going to draw out your line. Got a straight line here. And on the inferior aspect of C7, draw out another straight line. We'll go ahead through it and we'll do the same thing. T7, go the opposite direction, always towards the concavity. You always want to drive your lines towards the concavity. And on the inferior aspect of T12, superior aspect of L1. And instead of doing L5, we're actually going to do the superior aspect of the S1. So I'll just say around here. Alright, and now with this you're going to make perpendicular lines, you're going to draw them out, and you're going to measure where they intersect. So right here, this is where you'd measure. And for the interest of time, that you do the same thing for all of these other ones, is you draw a perpendicular line out. So you draw a line up here, and then here, and wherever they cross, that's the angle that they make. And then you'll be able to figure out what their degree of kyphosis or lordosis happens to be. And that's pretty much everything we covered in lab. As far as lecture, let me look here real quick. We went over blocked vertebra. And there's two things you need to know. There's two different types of blocks. You have a congenital block and you have an acquired block. Congenital block is you're born with it, and what it is two vertebrae or more are fused together. And the way you can tell the difference between an acquired block where they had a surgical fusion versus a congenital fusion is the anterior aspect of the vertebral body. If there's a concavity in the vertebral body, that means that this was a congenital block. if you look at, if when someone has surgery, then it tends to be like they poured cement up and down the vertebra. It's very straight, and it's really hard to tell any detail. But the big thing you want to look for is if you can see an IVF in the lateral X-ray. Because if you're looking at the lateral cervical view, you shouldn't be able to see any IVFs. If you do, that's a sign that it's almost guaranteed and that's going to be a congenital block. So keep that in mind. Schmorl's node. That's where you have the nucleus pulposus. It pushes through the vertebral end plate, and so if you look on the body here, what would happen would be you would have a little guy like this, a little deformity. So you'd see a line in your vertebral end plate right here when you're looking at it, and it kind of comes up, and it can be here or it can be here. So that would be considered a Schmorl's node, and there's not really anything you can do about it. Cervical, you can have a cervical rib, and that's where you have to differentiate that between just an extra long TP. You can have an extra long cervical TP, and the way you look for that is if there's a joint articulation. If you at the end of the TP it articulates with another bone, then you know that that is a rib. Now, is that a rib from the thoracic? And the way you look at that is you look at where the TP is it's pointing. If the TP is pointing up, then you're going to know that that's a thoracic rib, a normal rib, and it's not a cervical rib. If it's pointing down and it articulates, then you're probably looking at a cervical rib. And that pretty much wraps it up. Oh, we got a posterior ponicus. And that's where you create an arcuate foramen that traps the vertebral body. And I guess I was talking to the SI, and she said that three of their 5 patients have arcuate foramens, which is due to that. And so it's actually a lot more common than we think. And Dr. Kim in lab said that like 70% of the people he sees in the head and neck lab all have posterior ponicuses, so they're a little more common than we would think. So that wraps it up.